Morning, everybody. Dr. Gillard here. It is week 8, Thursday. This is the big GIGU lecture. It's spring of 2020. Off we go. Star of the show, or at least the first star of the show, is small bowel obstruction, otherwise known as intestinal obstruction. What the heck is that? And that occurs when something blocks or interferes with the flow of intestinal contents, in other words, fecal material or soon-to-be bowel movement. Something blocks that flow of fecal material through the pipes, and that's an obstruction. It can be a full obstruction or a partial obstruction. The movement, kind of the downstream flow, there's a word for that, or the distal movement of fecal material, that's called abral motion. Abral, that means flowing away from the mouth. And yeah, this is no joke. If you get intestinal obstruction, you're looking at 10-10 pain in the hospital. You will go to the hospital. Whether you have insurance or not, you will go to the hospital. It is also one of the causes of acute abdomen, which is 10-10 pain, 10 out of a scale of 10. On a scale of 0 to 10, how much pain do you have? 10 is in the hospital. You'll say that like a zillion times to patients over the years. This is a real cause of 10-10 pain. And there's other causes, but it's one of the members of what's called the acute abdomen. And who's the other members of the acute? That's a great question for me, right? To make an easy question, which one of the following is not a member or not a cause of acute abdomen? And appendicitis, acute appendicitis, cholecystitis, where a gallstone plugs the neck of the gallbladder. Urolithiasis is a kidney stone. All of those are horrible, horrible pain, including intestinal obstruction. You probably never heard of that until today, I bet. And then sometimes it happens and we don't know what happens. Probably a intestine got tangled up, and we'll look at some causes if we make it that far, what can cause that. There are two main causes of obstruction, general causes: mechanical obstruction or a functional obstruction. Functional obstruction means peristalsis. Moving the fecal material through the intestine is dependent completely upon what function? Peristalsis, right? So if you turn off peristalsis, you're going to have a massive intestinal obstruction. But that's usually not what happens. It's usually mechanical. Something physically blocks the lumen, whether it be coming from inside the lumen or coming from outside, pushing in on the intestine. It's a block of the lumen. So something is physically blocking the flow of fecal material. If it blocks the flow, it decreases the lumen. There's interluminal causes, extraluminal causes, and luminal causes. Let's look more closely at mechanical obstruction. So this is a little cartoon of a small bowel that has been, poop was moving across here and it got blocked. Some kind of beaver dam occurred here, and all the flow of fecal material stopped, and the bacteria went absolutely crazy in here, multiplied and multiplied. Bacteria release methane gas, and the intestines blow up and blow up. What's going to happen to this person's stomach? It's going to be bloated like crazy, right? They'll have a very bloated stomach. What are the causes of mechanical obstruction? Hands down, by far, and we'll talk about this later today, the number one cause is intestinal adhesions. And we'll talk about that. It's like bands of scar tissue that can form in the intestine. Intestinal hernias are also 10% of the cause. Example, an indirect inguinal hernia. Remember those from back in Gross 2 anatomy days? We'll be talking about those again. There's also intestinal carcinoma, 10%. You can get a cancer Maybe a cancerous polyp can grow and grow and grow and cause a block. It blocks the flow of poop. And there's other causes as well. One of the most common other cause, especially in children, is something called intussusception. Intussusception. And that occurs when the proximal part of the intestine kind of ferrets its way into the distal part. So we'll have a picture of it in a minute, but it's quite strange. But in adults, it's the number one cause of adhesions in adults. Okay, there's also another cause called volvulus, which is a twisting of the intestines. They can become twisted upon themselves, typically caused by adhesions is a very common cause of volvulus. Or you can have some birth problems where you get a congenital malrotation of the intestines. Right, here's intussusception. So here's the normal setup. Right, here's the cecum. There's the appendix here. Normally we have the distal ileum. We talk so much about this distal ileum. Here it is. But it can, usually we need a lead point. And we need something like scar tissue, something abnormal right here. And this acts as what's called a lead point. And through peristalsis, this can start pushing its way in and in and in and in. And that's called the intussusception. And that's the common place for it, actually, right there at that junction of the cecum with the ileum. Okay, that's the intussusception. Meckel's diverticulum, we talked about that in embryology. Meckel's diverticulum is notorious for kind of acting as a lead point and causing trouble. And then we can have just a twisting where the intestines get tangled up. Some of that idiopathic pain obstruction is probably a twisting of the intestines, and they are able to untwist themselves. People have these spasms of pain and attacks of pain, and then the pain gets better. But that's a volvulus. Usually you would have again an adhesion. Maybe you had surgery and it's coming. Here's your belly button right here, and they did a scar here for some type of surgery, and you can get those bands of scar tissue that form like that. Those are adhesions, and those are usually involved in these volvuli. More other causes. Stricture, that's a tissue buildup within the lumen, so it's kind of like the lumen gets scarred up. Patients who have chronic bouts of inflammation, Crohn's disease is notorious for this, or patients who've had radiation, have cancer, and they're getting bombed with radiation. That tissue builds up and it scars the lumen shut. It's like a beaver dam. This is a weird one, but this does happen as well. This is called gallstone ileus, and it's a complication of gallstones, cholecystitis. If you have stones rattling around in your bladder, and it's weird. What happens is your gallbladder fuses to part of your intestine. Like if this, I'll just draw the gallbladder hanging here. I mean, this is the liver. And you have an intestine loop coming by, and that gallbladder's been swollen up from being inflamed so many times. These two can connect, and because of the inflammation, you can actually burn a little hole in here. And therefore, the stones that are inside the gallbladder, they can work themselves through the hole, and they can get loose in the intestine. Right? And then they're off, and they roll on down the intestine until they come to the ileocecal valve. Right? You got to get through. That's hard to get through there, and they pile up, and they can cause an obstruction right there from piling up. That's called gallstone ileus. Gallstone ileus. And a fistula has to occur. Fistula is a communication between two pipes or two tubes. That's exactly what happens. They get stuck at the ileocecal valve. All right, so check out this patient. What do you make of this? Gotta put my glasses on for this one. All right, so this is the A to P, right? Here's the iliac crests. Get yourself familiar. All right, the liver on this side. Stomach over here, kind of superimposed on the pancreas, spleen's probably over here. But this is the thing in the liver you look for. There should never be any gas in or around the liver, and yet we have a little black spot, and that's indicative of gas. And that, in fact, is gas that has gotten into the gallbladder because there's a communication between the gallbladder and the small bowel. And the stones, just as we drew last time, they dropped in there. They went through the intestine, and they got stuck right about here. How do I know they got stuck here? Because we should see gas pattern from the ascending colon right over here. Do you see any gas? See lots of gas right here. Don't see anything here. So, yep, that's called gallstone ileus. Also, look at see how these look like kind of stacks? So that's called a stack of coin appearance. That is pretty strong evidence that the patient has obstruction. Okay, small bowel obstruction. How about some other causes of mechanical? How about external compression of the intestine? So what if you got a big tumor or a big lymph node that's swollen up to the size of a golf ball or even a tennis ball? It can push into the intestine and smash it from the inside out. How about foreign bodies? People swallow crazy things, especially people with mental health problems. Check this out. Well, that's crazy, isn't it? So 20-some-year-old, pretty young, you still see some epithelial plates here. Oh, this is a kid. Riser sign isn't even there yet. But yeah, you can see the spine, the ribs. What in the heck? So, you know, they play those marbles. We talked about marbles in lab. So those are steelies. Those are like boulder-sized steelies for marbles. They're like two centimeters. So he likes to swallow steelies. And the steelies got stuck. They can't go up the ascending, and I don't even know how they got it into the ascending colon, but they did. But they're stuck now. They can't get any further. So that's causing an obstruction in him. How are they going to come out? They're going to have to cut that out. Probably have to take that entire intestine. He'll lose that piece of intestine. What about the severity? Well, it depends if it's a partial block versus a complete block. Most of the time you get some passage of fecal material through a block, and so that'll cause pretty bad pain as well, but it's not as bad as having a complete block. That'll kill you really fast, but sometimes you can. And you'll become super dehydrated if you can't get fecal material through, including water. You'll be in big trouble then. Remember, you said the small bowel is very important at reabsorbing water, and if you got an intestinal block in the duodenum, you're in trouble. What's the sequelae? We said it's pain, bad pain. It's acute abdomen, 10-10 pain. Why is there pain? Because remember I showed you that picture, how it stretches way out, and the stretch receptors go, and it hurts. Dehydration is another big sequelae, especially more proximal located obstructions, because downstream you can no longer reabsorb water. And so what's that that's going to cause a whole bunch of problems, right? If you can't reabsorb water, what happens to your blood pressure? BP drops. Okay, what does that do? Well, we got to fix that problem. So increase aldosterone, right? So that causes the reabsorption of salt and water. But what else does it do? Increase salt and water, but decrease in this blood serum, decrease hydrogen ion, and what else? Good, potassium. So what's going to happen? Yeah, the patient's going to have metabolic alkalosis, right? Too basic, the blood's too basic, and they're going to have decreased potassium. So hypokalemia. So no good. All right, everything I just said. Dehydration turns on the R2A system. Malnutrition, I mean, if it goes on, if they have a partial block and it goes on for months, then the patient has attacks of pain, then they get better and attacks of pain. They can become malnourished from this. And you can tell it's a late one. I'm up late tonight doing this one. What's the sequelae of this? Intestinal wall ischemia. I mean, if the intestinal wall stretches out far enough, it's going to smash the drainage system of the affected small bowel, and the tissue is going to start to die. So you become necrotic, and bacteria can get into that necrotic tissue and burn a hole right through it. And now you got yourself peritonitis. The bugs and fecal material are loose in the peritoneal cavity, and that gets into the bloodstream real quick, and now you got yourself septicemia, and you can die quickly from that. Just to remember, I'm not going to go through all these layers. We talked a lot about the different layers, the different muscular layers, but the point of this is, here's the lumen. So what if you get a huge beaver dam right here? What if something is blocking the intestine? Well, as it gets bigger and bigger, it can squish these blood vessels and pinch them. And you need these blood vessels to keep this part of the intestine alive, so that intestine will die. And it can become perforated, and you get peritonitis and septicemia. Sorry, I can't give you warnings. Can't see what's coming. So this is surgery. This looks like probably one of the inguinal hernias down in the inguinal region. But the intestine was, I think this was it's a strangulated piece of small bowel. So it was probably a indirect inguinal hernia. But whatever it was pinching, and we'll talk about this in a while. It was pinching so bad, this is all necrotic tissue now, right? This died because it didn't get enough blood. So this doesn't look so good over here. So the surgeon's going to have to cut all this out, sew those back together again. So no good. Became strangulated. How about some more clinical signs of small bowel obstruction? What's that gross stuff? That's bile. That's bilious eminence. So one of the first, especially in kids, one of the first signs of small bowel obstruction is they start throwing up bile. And I don't know what it is about it for sure. They don't quite understand, but because normally bile is only released with fatty food and meal, but when people get sick, it starts to kind of drizzle out, and especially if they throw up, all the force that they put into throwing up might squeeze that gallbladder and squirt more bile out, and it can certainly pop it right through that pyloric sphincter, no problem. That's not a good sign. If you ever see someone do that, they need to go to the ER. Bilious eminence is usually the first sign of small bowel obstruction, and we actually know where the small bowel obstruction, it has to be downstream from the major duodenal papillae, because that's where bile gets into the small bowel, right? How about some other clinical signs? Well, their belly's going to be swollen, right? They're going to have abdominal distension from the bacteria that have went wild in the area. Okay, bad sign, little kids' blankets all filled up with bile. Bilious eminence. So this is lots. Look at all these stars. You need to know about colicky pain. You'll run into this. Guaranteed you'll run into this, either in your family or one of your patients. Colicky means it's caused initially when you have a blockage and the fecal material can't get through, and it starts to stretch the intestine, and body senses that, and it tries to push really hard, really forceful peristalsis occurs and tries to push through that blockage. And sometimes it works, sometimes it doesn't. But every time the peristalsis ramps up, it squeezes harder and harder. That's called a crescendo pain. And those pains will come on so strong, and you just lay on the ground and wish you were in the hospital, and then it backs off. It starts to feel better. And then in 3 minutes later or 5 minutes later, almost like giving birth, the pains come back again. That's a colicky pain. That is a sign of small bowel obstruction. Clinical signs: patients with partial obstruction. If there's a blockage in the pipes, there's not going to be much fecal material to come out. So you'll have, and plus you'll be all dehydrated, right? There's no water getting down there. So the poop that does get through is going to be very dehydrated. So you're going to be constipated, right? Definition of constipation is having less than 3 bowel movements per week. You have to know this. I do like this slide. Obstipation. I almost always put this slide on here, so make sure you know this. Obstipation is one of the chief clinical findings of a complete block. And these people, they have not had a bowel movement sometimes in a week or two. And by definition, obstipation is severe constipation with no bowel movement. Or maybe they had one, but they're self-impacted. They had to literally put their fingers in there and pick at the poop and block it up to help get it out. Oh yeah, that stuff can happen. That's obstipation. Tachycardia, hypotension, other signs. Well, if you're going to be dehydrated, the heart's going to try to make up for that by beating faster. Probably have tachypnea as well. So hypotension, we talked about that. Hematochezia, that is not a good sign. Hematochezia means bloody bowel movements, reddish in color, not melenic, not a melena stool. Very dangerous. That means that the intestinal wall has been breached. The bacteria have burrowed a hole in the lumen, and it's bleeding. So that's a bad sign. Distension, we talked about distension. Distended abdomen with or without pain. What about auscultation? We've talked about that as well. So you might hear hyperactive bowel sounds. We talked all about that. If it's early in the block, we have that will go along with decrescendo pain. However, if it's really late in the blockage, maybe 6 hours, the bowel sounds will stop. The body will stop trying to push through the blockage, and everything will be quiet. You're filled up with gas, nitrogen gas or CO2 from the bacteria releasing that. When you percuss the abdomen, it's going to be very tympanic. There's not going to be, remember we said the normal percussion note of the abdomen is tympany, but it shouldn't all be tympanic. There should be some areas of dullness in there where there's some fecal material. And these people are going to percuss like a drum. A deep palpation, you're probably not going to be able to do deep palpation on these people. Probably too painful. They may have voluntary or involuntary muscle guarding. Involuntary muscle guarding is a bad sign. The indication of peritonitis has happened. That's where all the flap muscles and the rectus abdominis muscles, they have all went into spasm trying to protect that area. So that's a bad sign. Signs of peritonitis may be there. Peritoneal signs may be present as well. What are peritoneal signs? This is a good question. Slide to make questions from, isn't it? So super tender to the quadrant that is involved. You might not be able to even palpate it, or maybe even percuss it if it's that bad. But you can have the patient do the cough test. So these are just some signs to see that if they have peritonitis. You have them cough or bear down and see if they have horrible pain right in the quadrant that's bothering them. Again, if they have rigidity, involuntary muscle spasm, that's a bad sign. That's a peritoneal sign. Rebound tenderness. If you poke, first you always want to try to poke away from it. If they have right lower quadrant pain, I taught you this in lab, then you push your fingers into the left lower quadrant, and then snap your fingers up real quick. See if that causes pain in the right lower quadrant. And then if it doesn't, then gently push into the spot, the right lower quadrant. And if that causes pain, you're done. You don't do any more. If it doesn't cause pain, push in and then rebound. Let your fingers off and see if that causes pain. If it does, it's a sign of peritonitis. It stretches the peritoneum. If it's inflamed, it's going to hurt really bad. Okay, if the patient has any of these peritoneal signs, they go right to the ER. Rebound tenderness, this is McGee. Great test. There's some research on rebound tenderness, even though it's kind of an inhumane test. There's some pretty good research for early peritonitis. And so this is, you'll push deep into the quadrant where the pain is. So this isn't the test for appendicitis where you push appendix is in the right lower quadrant. You push in and rebound, let the fingers snap in the left lower quadrant. This is flat out wherever the pain is, you push in there, and then once you get deep enough, you suddenly, without warning, let the pressure off. Pull your fingers out of the abdomen. If the patient has really bad pain on withdrawal, pretty good indication that they have peritonitis. Many surgeons, however, discourage the use of this test. There's better ways to figure things like this out. We can order a CT and blood work, and we can figure this out without torturing the patient. Right? This patient has right quadrant pain, right lower quadrant pain. So this is the good old-fashioned rebound tenderness. You push into where the pain is and then quickly let your hand go out. If the pain has pain, the test indicates peritonitis. Everything I said stretches the peritoneum, allows it to snap back into place, and increase pain with the rebounds. Positive finding. Again, test is not needed in patients with rigidity, because if they have rigidity, involuntary muscle guarding, you're done. There's no sense of going any further with it testing. They have peritonitis, they need to go to the ER. What does a positive rebound test indicate? Early peritonitis. Is it a medical emergency? It is a medical emergency. They need to consult a surgeon. What kind of surgeon do you send them to, by the way? General surgeons are the ones. I mean, they're going to be in the hospital, but general surgeons do this. Then we have Rolfsing's sign. If you do suspect it, we talked about this in lab, but if you do suspect peritonitis, or if you do suspect a gallbladder is the problem, cholecystitis or appendicitis is the problem, you can do Rolfsing's test, and you push into the left lower quadrant and hold it and see if it causes right lower quadrant pain. And if it is, there's a decent chance they have appendicitis. This is not a rebound test. If positive, it strongly indicates appendicitis. Okay, patient goes to the emergency room. Guarding versus rigidity, kind of talked about that. Guarding means that the patient is voluntarily contracting the abdominal muscles to stop you from poking, because they know if they poke in there, it's going to hurt. Okay, rigidity, as we said, that's involuntary. They can't, no matter what they do, they can't relax. And that's a bad sign. They go to the ER. What are the odds that peritonitis has occurred with positive guarding? Doubles the likelihood. That's decent, but that's not great. But rigidity quadruples the likelihood that they have peritonitis. So that's pretty indicative. How about some other common causes of guarding rigidity? Appendicitis, we talked about, cholecystitis, perforated bowel. a small bowel obstruction. Kind of know all that stuff already. Ooh, I like this slide, don't I? Lab findings of small bowel obstruction. So when they first come in the ER, they may be normal. Their values, they may look a little dehydrated, but their values may be normal. But as the course of this progresses, they will reflect values of significant dehydration, i.e., we talked about this, early alkalosis and hypokalemia. We talked about the mechanism of that. And that's all because the intestine's not taking up water. The intestine is very important for sucking up water and keeping your blood volume normal. And so you lose that, turns on aldosterone, R2A system's turned on, and angiotensin 2 is released, aldosterone is released, and if that's enough, hydrogen ions still get kicked out of the blood into the intestine. I mean, think of here's the intestinal tube. Think of that intestine as the filtrate, just like one of the tubules, the renal tubules, because the same stuff happens. Water and salt are taken out, and hydrogen ion and potassium are put in, and the same thing happens there. So they lose hydrogen ion not only into the filtrate, but they lose it into the intestine as well. They might have a elevated white cell count at this point. This pretty strongly indicates small bowel obstruction. Even worse, strangulation it indicates. Get that out of there so you can see that. Strangulation means it's usually a hernia causes this, but it could be a volvulus or intussusception. That means the intestine is actually dying. So that's definitely not a good sign. Plain films, they're also they have pretty high specificity, up in the high 80s, for making the diagnosis. And this is stuff that we take as chiropractors, right? You'll take films like this. And so there's the dilated loop of bowel. So if you see gas in the bowel, the stack of coin appearance, I already showed you that. We'll look at it again. Sometimes you could see air fluid levels, and sometimes you can see downstream from the block there'll be no gas. Kind of looked at that as well. And even worse, there might be free air inside the abdominal, or inside the intestine itself, or inside the abdominal cavity, so that all that gas from the bacteria that was cooped up and the intestines were getting bigger and bigger and bigger, those intestines finally popped and released gas. What do you make of that? Well, I take a drink of water. That's got to be a supine image. Can't see this in standing. You have to be supine to see this. But yeah, look at, there's a stack of coins, right? Really nice stack of coins. All way too much gas. So this patient's in trouble because the stack of coins is like everywhere. So that means the blockage is way down low. So maybe they'll be able to reabsorb some water maybe, but after a while they won't. So it's probably, the blockage is probably down in the jejunum, or ileum, I would guess. Don't see any. Do you see any large bowel gas? I don't see it anywhere. Classic small bowel obstruction, dilated loop of small bowel, stacked coin, everything we talked about. How about air in the biliary tree? We talked about that already, right? The gallstone ileus. What else? Gas distension is uniform through the stomach, intestines, colon. So if you have this gas that's distributed pretty evenly could be a sign of ileus. So far, the small bowel obstruction I've shown you, we've only seen the small intestine affected. But in a case of ileus, remember that's when peristalsis isn't working. So it's like you have a gigantic intestinal obstruction. Your entire small bowel and large intestine is not working, so it's like a gigantic obstruction, and you can have huge amounts of gas from this. So that condition is called ileus, or aka paralytic ileus, or aka adynamic ileus. And it mimics a small bowel obstruction, but there's really no physical obstruction. It's a functional type of obstruction where the intestine has just stopped working. How about the causes of ileus? Peritoneal injury is very common after surgery. Cutter goes in there and cuts into the peritoneal cavity right through the parietal peritoneum. It shocks the peritoneum and it shocks the intestine to be handled. They're pulling the intestine out in some surgeries, pulling it right out. That's traumatic for the intestine. And when you close up, the intestine doesn't work. And that's very common. It takes a while for it to kind of wake back up. About 1.5% people have trouble with this after surgery. Hypokalemia is, so what do we know hypokalemia is caused from? Small bowel obstruction. So the hypokalemia from especially an untreated small bowel obstruction can turn into ileus in some cases. And drugs, antidepressants, opioids, histamines, antidepressants, specifically the tricyclic, not the SSRIs, but the tricyclic antidepressants, which old-timers use a combination of antidepressants and opioids for severe pain. People with chronic pain, not so much opioids anymore. Surgeons or pain management docs are scared to death of those things. Don't get me started on that. It's kind of, I got started a little bit. It's kind of sad to see, I do a lot of coaching every week. I talk to patients all over the world, and they can't get any meds anymore. It's very rare I see anybody on opioids anymore. Everybody back in the early 2000s or late 2000s and early 2010s or whatever that decade was, however you would say that, 2010, 11, 12, 13, boy, they were prescribed maybe too liberally then. I think the pendulum has went too far because people do need them. Chronic pain patients do need these things. Yep, so they can do it. Peritonitis can do it. And abdominal aortic aneurysm has been known to cause ileus as well. Wow, what do you make of that? That's crazy, isn't it? That's definitely crazy. Now look at that transverse colon. Yeah, so this is ileus. So this is a patient who is on pretty high doses of opioid, Percocet, combination of tricyclic antidepressants. Stomach wasn't feeling good, and he went to the ER, and this is what they found. How about some differential diagnoses for small bowel obstruction? Mesenteric artery ischemia is one, typically from a beaver dam in the superior mesenteric artery. Could be the inferior mesenteric artery as well. But yeah, you get a beaver dam in there. Maybe it's from, we talked about AFib a little bit. We'll really get into it in a while, CVPP. But AFib can throw arterial embolisms, and if they don't go up and damage the noodle, they can go down and get stuck in, let's say, the superior mesenteric artery, and they can knock out a good piece of your small bowel because the distribution of that. These mesenteric artery ischemia produces colicky abdominal pain as well. Remember the superior mesenteric artery? There it is right there, right? Celiac trunk, next one up. Superior mesenteric artery. We had all those intestinal arteries, we called them. It's really jejunal and ileal arteries. It supplies all of the small bowel, superior mesenteric. You get a beaver dam in here, that's not a good thing, right? Because you're going to take out all the small bowel. And even the ascending colon has branches, right, going over there, as well as here. So, yeah, not a good artery to get a embolism in. But that could be a differential diagnosis. Colon obstruction, how can you tell the difference between small bowel obstruction and large intestine obstruction or colonic obstruction? Very easily confused. There's probably no bilious eminence with colonic obstruction. Severely distended abdomen. I mean, where was that? Where was that picture? Look at that abdomen. Can you imagine percussing that thing? Yeah, the management is still the same. Still see gas and radiographs. So what is the treatment for small bowel obstruction? Well, you got to treat the diarrhea, or the diarrhea. You got to treat the dehydration so the patient doesn't die. So fluid resuscitation, IV, lots of fluids, electrolytes. No food, obviously. Don't add to the beaver dam by piling more food in there. And then you just watchfully wait 4 to 6 hours. Maybe the blockage will work itself out. And that's what you're hoping for, and oftentimes it does. But if it doesn't, the surgeon has to be called in, and I mean, if it gets bad, you're going to have to go laparotomy. There's different ways to do it, but laparotomy is probably the best. Pump a little gas in your stomach, put a scope in there, and cut out the problem. If there's a beaver dam, you're going to have to cut around it and take that whole section of intestine out. Incarcerated hernias. So if that's the cause of the small bowel obstruction, you can try to reduce those by manually pushing the hernia back in. So that's possible. And strangulated, what's the treatment for these things? So if it's strangulated, that means that well, we'll come to that. But that means that it's whatever is causing the beaver dam is compressing, whether it be just the backup of fecal material, whether it be the scar tissue, the adhesions, whatever. If the intestinal wall is pushed or pinched so bad that blood flow is interfered with, you're going to have the intestinal tissue start dying. And when that happens, it's called a strangulation, and that's a medical emergency. That intestine bursts and all that fecal material gets dumped into your peritoneal cavity. You don't have you have a chance of dying from that. That's really serious. Okay, prompt surgical intervention for people with strangulations. And yeah, the mortality rate associated with gangrene, someone's waited way too long. Even in a good hospital, some 30% of people will still die. So it's a very serious problem. What's the prognosis? Kind of just said a big death rate if you don't get it treated. But what's the post-operative mortality for a non-strangulated simple obstruction? It's actually very low. It's below 1%. But for a strangulated obstruction, that has an 8% mortality rate, even when you catch it quickly and perform the surgery within 36 hours. Much higher, probably 15-20% if you don't catch this early. So it's, again, you can die from this. It's a serious problem. Let's see how we're doing on slides. Oh, we got a long way to go. Although I'm doing good on my slides, though. Let's see, 56, 60, that's like 40. That's like 50 slides, so we're doing pretty good. Adhesions. We said that was the number one cause of these obstructions. And yeah, in adults anyway. So adhesions, also known as intra-abdominal adhesions, they're the most common cause of small bowel obstructions in adults, are these adhesions. Usually after someone's had a surgery, they form. About 75% of the time, a person goes in the ER with acute abdomen and signs of obstruction, the culprit is adhesions. In children, remember, intussusception is the most common form of small bowel obstruction in children. What are they? They're scar tissue bands. They're intra-abdominal bands of fibrous scar tissue, and they can attach to intestines, and intestines move when you're doing peristalsis. Those intestines are free to move around a bit, and they can get twisted and tangled up if they have these tethering adhesions stuck to them. Right? There's a picture of one. Surgically in a patient with small bowel obstruction. This tissue right here, it's not supposed to be there. All this, I'll draw the outline of it. Right, all there. Not supposed to be there. Got the intestines all tangled up, and yeah, it's an adhesion. Typically found running between adjacent intestines. They run between intestines and the abdominal wall. They can run between intestines in the wound from an old surgery. Kind of drew a picture of that before. There's a nice picture of one. Intestines have strangled this loop of bowel, and it's becoming red and ischemic. And if something isn't done, if it doesn't wiggle itself out of this trap, this tissue starts dying, you're going to be in trouble. You'll be very symptomatic, 10-10 pain with small bowel obstruction secondary to adhesions. Real picture, another one. Patient with chronic abdominal pain, and it got really bad, and you can see a big adhesion band right here. Looks like the beaver dam was right here, because look at how big. Small bowel is really way too big right there. Right? So, getting ready to clean that up surgically. Most of the time, you can have adhesions following surgery, and you have no clue that you have them. As long as they don't have any pain fiber in them. So, as long as they don't tangle up intestines, you'll be fine with those things. About 12% of the time, though, they can become symptomatic with abdominal pain, probably from temporary obstructions forming and then releasing. About 3% of them end up having surgery because they cause a significant mechanical obstruction. Why do we care where they came from? Or where do they come from? The peritoneal cavity injury from surgery, cutting through the parietal peritoneum and then sewing it back up, can result in an out-of-control fibroblast-heavy inflammation, and it makes scar tissue. Okay, especially surgical procedures of the abdomen are notorious for causing adhesions. And congenital adhesions, you can be born with a persistent vitalin duct. We talked about that in embryology. It's rare, but it can happen. The cord that forms between the persistent vitalin duct that can get tangled up in small bowel. What is it specifically about surgery that causes? What really causes adhesions? Well, it's damage to the peritoneum, as we said. But when you're doing surgery, you're exposure to intestinal contents. So peritonitis, subclinical peritonitis has occurred. That's enough to get the inflammation started. Or powder from surgical gloves, surgical gauze particles that get stuck, sutures, overheating the intestine with lights from surgical lights. Some of the fluid that's used to irrigate or cause them. There's a lot of theories behind why they occur. And there's probably a genetic propensity as well. What about the timing? So if you just had surgery, how long do you have to worry? Usually within the first year. If they're going to become symptomatic and start strangulating things, usually happens within 1 year. It's not always the case, but that's kind of the rule. It could happen anytime 5 years later, but usually within one rule. Okay, hernia. Let's keep going. I guess, should we keep going? Yeah, we should keep going a bit more. Small bowel hernias in general. This is a big topic, right? Hernias. I think you know a little bit about these. That's probably back in first or second quarter, so you probably forgot. But yeah, you see one. Can you see it? Right there. That's called you remember the? I don't know if did I have you guys for anatomy. I always made the gross 2 students learn the linea semilunaris. It wasn't in the lab notes, but this is the moment why I had you memorize that, because you can get a hernia through the linea semilunaris, and it has a name. It's called a Spigelian hernia. Spigelian hernia. What is it? It's a defect in semilunaris that lets intestinal loop push right through that region of linea semilunaris. All right. So what is it? Small bowel hernia. Well, small bowel herniates, right? Occurs when the small bowel herniates through a weakness or a defect in the anterior abdominal wall, right? Or in the inguinal region, like down the inguinal canal. Occasionally it could herniate into the lesser sac. Rarely it could even herniate into the retroperitoneal cavity. So small bowel hernias account for about 10% of mechanical small bowel obstructions, account for about 30% of small bowel surgeries, have a high tendency to incarcerate, so they are quite pesky. And when they incarcerate, you can get a strangulation, right? Incarceration means the bowel is trapped in whatever the defect is, usually a defect in the anterior abdominal wall. But the blood supply can start to get pinched off, and now you're going to become incarcerated, and you're going to become strangulated. And that strangulated means your basically tissue is dying, and that needs to come out quick. How about the parts of a hernia? So we have an abdominal wall hernia, or abdominal wall hernias have 2 main parts. A little bit different down when we talk about groin hernias. But for abdominal wall, there's 2 main parts, and there's an orifice, which is also the hole in the abdominal wall which the intestine pushes through, and then the part of the intestine that is now outside of the abdominal wall, that's called the hernia sac. Hernia sac. Okay, that's always a good question. What's the hernia sac contain of? Well, probably some skin, but definitely parietal and visceral peritoneum, and the intestine, maybe some greater omentum. But yeah, here's a run-of-the-mill hernia, Spigelian hernia. This could be a Spigelian hernia through semilunaris. Could be an umbilical hernia. There's a lot of different ones it could be. But nevertheless, the intestine and I guess this is superficial fascia, and this must be a lower abdominal hernia then, because there's no omentum coming out. But this is just a cartoon to show you. The hernia sac is everything outside of the body. Hernia sac. What's in the hernia sac? Well, skin. There's definitely peritoneal layers here, and then the intestine itself. The defect through which it herniates is called the orifice. The orifice. Hernia sac and orifice. Remember, I got to throw this slide in here, right? What are the layers of the abdominal wall? Stick a pin through the rectus abdominis. Name the layers. And then we'd have to tell you, well, are we above or below the belly button? Because they change a little bit. But if you're above the belly button, skin, the pin would go through skin, which is epidermis and then dermis. It'd go through the subcutaneous tissue. It'd go through the muscle in our little case here. It's the rectus abdominis. And it would go through the rectus sheaths. And then we would finally get through that, and we'd come to the deep fascia. This is the deep fascia layer right here. the deep three: transversalis fascia, extraperitoneal fascia, also known as preperitoneal fat, and then parietal peritoneum. That's the deep fascia. And then we're into the abdominal cavity. But if the pain keeps going and goes through intestine, well, it'll go through the greater omentum next, because we're above the belly button. Then it would go through the visceral peritoneum around the intestine, and then it would go through the intestinal wall itself into the lumen. Definitely need to know those layers if you don't know already. And here's just the cartoon. I mean, I'm not going to go crazy on this. But here's the muscles. These are called the flat muscles. We have the external obliques here, right? The next layer down, underneath those, internal obliques. Now we've cut away, there's fascia here, but we've taken all that away. Then we have TA, transversus abdominis, is down here. Okay, then the fascia of these flat muscles makes up a sheath that corrals the rectus abdominis. And there's an anterior rectus sheath here in the front, and there's a posterior rectus sheath here on the back. Right? And there's veins and arteries that run through there. It's the inferior epiploic, or is it epiploic? I'm trying to think if I remember that. My brain's mush right now. Anyway, this is important. Arcuate foramen, right? Or I'm sorry, arcuate line. Jeez, I am getting tired. Arcuate line here. Well, what is that? What is that arcuate line? Not everybody has one. It kind of fades out in some people. Well, that's the end of the posterior rectus sheath. So there is no more posterior rectus sheath. Usually comes below the belly button, about halfway between the belly button and the symphysis pubis here. So that's interesting. All the layers, the aponeurosa, the flat muscle, and the anterior rectus sheath is now a little extra thick here, but you do have an extra, it makes it a little bit easier for intestine to herniate out, because the anterior rectus sheath isn't that much fortified by these things. So that is a weak spot. And make sure we know this one, right? There's linea semilunaris. Linea alba, make sure you know that for some types of hernias that occur. Defect in linea alba, linea semilunaris. You can even have, these are called tenderness intersections that give you that washboard abdomen. You can have defects in that as well. So there's our little mini anatomy review. Great board stuff right here. You probably sure Musavi got you with this stuff. But remember, above the belly button, here's the rectus abdominis. This is the cross section. It's like we're looking, well, it's an axial cut. Axial cut. Here's the rectus abdominis muscle above the belly button. Here's the anterior rectus sheath. Point of this video, is to show you the anterior rectus sheath is actually made by the external oblique aponeurosa, and each one of these aponeuroses has two leaves. So both leaves go around to form the anterior rectus sheath. The internal obliques is the weird one, right? This guy is really weird because its anterior leaf goes anterior to help form this anterior rectus sheath. But weirdly, its posterior sheath goes around the back side of the rectus abdominis to form the start of the posterior rectus sheath. And then transverse abdominis, both of its leaves go to fortify the posterior rectus sheath. So the old stick a pin through the rectus abdominis question can be a little tricky if you want to get specific about leaves, because it'll be skin, subcutaneous tissue, and then you'll go anterior and posterior leaf of external oblique, anterior leaf of internal oblique, rectus abdominal muscle, posterior leaf of internal oblique, and anterior and posterior leaf of transversalis, transversus abdominis. That should be that's right, transversus abdominis. And then you can keep going. Then you hit the deep fascia. So transversalis fascia, preperitoneal fat, and parietal peritoneum. Remember those from lab days? But look down below the belly button. If you go, about halfway down between the belly button and civis pubis, where's the posterior sheath? Yeah, it's gone. All the leaves go anterior, form an anterior rectus sheath with no posterior rectus sheath. So weak spot right here for hernia. Some general types of hernia. External hernia, that means the hernia sac is protruding through the abdominal wall defect. By far, most hernias that you'll run into are external hernias. They have to be in the abdominal wall or the inguinal region. Not uncommon for these to have greater momentum in them as well. Internal hernias are more rare. So you can have, there's two classes. There's retroperitoneal internal hernias and abdominal cavity internal hernias. And this is a weird one, and this happens a little more often. Remember the foramen of Winslow in the lesser sac? Of course you don't. What am I showing you here? Oh, we've covered this before in CVPP, but that's the interperitoneal peritoneal cavity, right? Anything inside here is interperitoneal. Anything back here is extraperitoneal, like the pancreas, the kidneys. Those are extraperitoneal organs. Ascending, descending colons are extraperitoneal. But this is the retroperitoneal cavity or space back here. So we can get hernias that occur into this retroperitoneal space. Where am I missing a slide? Am I going crazy? No. Okay. It's like, where's my foramen of Winslow slide? All right, so you can get a hernia into this. That's pretty rare, though. But a Richter's hernia is one type that can do this. We'll look at that more in a minute. This is the one I want to show you some good anatomy here. So there's the greater curve A to P view of the abdominal cavity with all the skin removed so you can see the stomach. Remember, the greater omentum goes down to below the belly button a little bit. Where's the lesser omentum? Here's the lesser omentum. It's more membranous. It's made by two ligaments, the hepatogastric and the hepatoduodenal ligaments. Together they make up the lesser omentum. Who cares about that dumb thing? Beneath this, in back of this, there's a little cave here, and it only has one entrance. You have to go through this opening. That's called the foramen of Winslow. When they're doing an appendectomy, the surgeon has to stick his fingers through the foramen of Winslow to grab a hold of the cystic artery and tie it off before they can remove the pancreas, or he's going to have a big bleed. So if the surgeon's fingers can get through the foramen of Winslow, also called the epiploic foramen, guess what else can get through there? Small bowel. So you can get small bowel hernia through the foramen of Winslow, and that's an example of an internal hernia. Internal hernia. Here's some terminology. So we have a reducible hernia. That means that it can be pushed back in if it's popping out of a defect in the linea elbow, let's say this time. You can pop it back in, then it was a reducible hernia. If you can't pop it back in, then it's called an incarcerated hernia. Non-reducible, irreducible hernia. Okay, these are in trouble because the venous blood vessels are delicate, and you're not going to be able to get blood out of that entrapped intestine. And pretty soon, swelling's going to occur, and it's going to pinch off the arteries, and that whole section is going to become ischemic. And when that happens, once it starts becoming ischemic, now you have yourself a strangulated hernia. Very dangerous. It can pop, cause peritonitis, which can cause septicemia. Richter's hernia, what does that mean? That's kind of weird hernia. That occurs when only part of the small bowel herniates through an abdominal defect. So you have a hole in the abdominal, the anterior wall of the abdomen, and the intestine pokes out, but the entire intestine doesn't go out. So about half of the intestine is out, half of it isn't. So here's an example. This is the internal inguinal ring. So we have a hernia going through the inguinal canal, but it doesn't go all the way through. Or we have an intestine going through the internal inguinal ring here. Same with femoral hernias. These are they are usually Richter's type hernias because the entire intestine wasn't sucked in here. Just part of it was. And when part of it is still letting fecal material go through, but some of it is herniated and the fecal material can get stuck and it's a bacteria feeding frenzy there, that's called a Richter's hernia. Okay, can still strangulate everything I just said. Internal hernias, femoral hernias, obturator hernias, internal hernias. Yeah, those are all good examples of Richter's hernias. What about femoral hernias, obturator hernias, inguinal hernias? Yeah, we need to go a little deeper. Let's get into the groin region now. I'm debating to stop, although, what time is it? Because I'm not taking any breaks. It's like over an hour. How many slides do I have? We started on, we'll say 60, that's 40, that's 78. God, that seems like enough slides, doesn't it? Let's do a little bit more, though. It's supposed to be 3 unit lecture, just a little bit more. How about some groin hernias? We'll just talk a little bit about it, and that's it. So groin hernias, groin is defined as the region where the inguinal ligament is, runs between the ASIS and the pubic tubercle. Groin hernias, that's a general term which describes hernias in the groin region. Groin hernias are under the category of abdominal wall hernias. So this is the parent, abdominal wall hernias. Now, all surgeons don't agree on this, but this is the way we're going to go. So groin hernia is a member of the abdominal wall hernia family. There are 2 major types of groin hernias. Some of these you may know. We have inguinal hernias, right? There's two types of inguinal hernias, direct and indirect. We'll definitely talk about those next time. And then we have femoral hernias. That's the least common one. That's usually a Richter's type hernia through the femoral canal. And let's see, the most common type of any hernia in the planet are the inguinal hernias. They are, if you're going to run into a patient with a hernia, it's going to be probably a direct or indirect inguinal hernia. What about naming the groin hernias? So it's not universally accepted the way I just told you. Some surgeons consider groin hernias as an AKA for inguinal hernias. And they don't include femoral hernias in that category. We're not going to do this. So groin hernias will be the parent category, and inguinal and femoral hernias will be the child category. There'll be subcategories of groin hernias. Okay, and there's really complex. It's got really way too deep for us. This NIFUS classification system is how hernias are really classified, but that's way too deep for us. All right, inguinal hernias. Let's stop. That's a good place to stop. I'm fried, and you guys are probably fried too in week 8. That's plenty of slides for you. All right, we'll see you later for CVPP, and then I'm done with you after today. All right, bye-bye.